My disclosures. I've got not antibodies to SARS-CoV-2. I'm fighting every day like all of us. In Lombardy, this is a short story of epidemia. First case, 18 February, and first red zones 5 days after the 23, Lodi and Codogno, that are two small countries close to Milan. And 17 days after, completely locked down for Italy, and Lombardy became to be the most important area of epidemia in Lombardy. So the Regione Lombardia, so the government of Lombardia, decided to organize a network of vascular emergency, of cardiovascular emergency in the region. So are created 4 hubs for vascular surgery. San Raffaele Hospital in Milano, Monzino Hospital in Milano, Poliambulanza Hospital in Brescia, Legnano Hospital, and San Donato Hospital in Milano only for pediatrics. And the most important response that you need to the population for emergency or COVID was been the creation of new COVID beds. You see the new ICU built inside a sport tensile structure. And you see the work for construction of the ICU in an area for tennis, and you can see the final result with the tensile structure completely renovated and appear 24 beds built in 200 hours, bed of intensive care. In total, in San Raffaele Hospital, we have 5 new ICU, 57 beds, 300 non-ICU dedicated beds, over 700 patients with severe SARS pneumonia admitted, and a donation from private citizens over 4 million euro. The network worked like San Raffaele, like hub for vascular surgery. You have 9 spoke hospital, you see, that stopped completely with vascular surgery and envoyed to San Raffaele Hospital all the emergency. The vascular surgeons worked in the other hospital are used for COVID emergency. And we destinate an area COVID-free for emergency room with, you see, a dedicated entrance, and you created a new emergency room with 7 beds for first evaluation for emergency. And this is the surgeon, in this case are me, dressed for to do surgery in this situation. You used all personal protective equipment, PPE, prepared by Giorgio Armani for Milano. And now I will show to you 2 cases interesting of aortic emergency. 70 years old, AAA with gore for aneurysm in 2018, and transferred from the other center for abdominal pain and fever. CT scan, suspect of endotension, diameter 5 to 1 to 5 to 7 in 2 months. The patient admitted with fever over 38 and persistent pain. Swab test, you see positive for COVID, have a typical CT scan chest, positive pneumonia, COVID. Patient transferred to infective disease unit to treat pneumonia with non-invasive ventilation needs. fever remission, but persistent abdominal pain. So you did, for the worsening of the abdominal pain, a new CT scan. You observed a type 1 endoleak for migration of the prosthesis with final diameter of the aneurysm 6.9. This sagittal view of the CT scan with migration and proximal type 1A. And this is an axial view with diameter from 5.9 to 6.9 centimeter in less than 2 months. So you decide open surgery. You see a clamping between the renal arteries. You see aortotomy with thrombus removal. You see the perfusion of the right kidney with custodial, and complete endograft removal, and reconstruction of the aorta with silver-coated prosthesis with proximal and distal anastomosis. Here the final result, and this the removed endograft. And the first postoperative day, the patient in intensive care presented a right side abdominal guarding, metabolic impairment with hepatic failure. So you decide emergency CT scan, and you can observe a early thrombosis of the celiac trunk at the origin. Here, the particular of celiac trunk near occlusion, treated with emergency stenting, cholecystectomy, and a colonic resection for large bowel ischemia. Possible causes, malperfusion or disseminated intravascular coagulation. Patient, fortunately, is alive, extubated at 11 postoperative day. Another cases, car accident for a patient with alcohol abuse, head injury and the right scapular fracture, type B, traumatic aortic dissection. You see the admission CT scan, proximal entry tear, and celiac trunk from false lumen, superior mesenteric artery from true lumen, renal from true lumen, dissection of common iliac artery. In emergency, TIVAR in zone 2 under rapid pacing with good result observed with the postoperative CT scan with good exclusion of the proximal entry tear and patency of the visceral renal vessel, but the patient had a good result, but you see the chest at dismissal suspected COVID positive pneumonia. Our experience in the first 5 weeks, like hub for emergency in Lombardy. Total patient 85. In this weekend, become 91. COVID patient 31. In particular, 41 lower limb, 44% limb revascularization with COVID, 7 major amputation, 57% COVID, aortic emergency, 17, 24% COVID, 9 carotid artery stenosis, 2 iliocaval venous obstruction, 1 COVID, and 9 mixed operation, 3 ECMO and impella, 2 popliteal aneurysm, 2 common false aneurysm, 9 and 32% COVID positive. In particular, aortic emergency, you see 17 and 24% COVID, 8 emergent treatment for AAA, 3 COVID, 3 thoracoabdominal, 1 arrived during the weekend, died at admission into hospital, 2 typedic section, 1 COVID, 2 typedic section treated with FET, 1 orthoenteric fistula, 1 descendant thoracic treated with endo. And we started with very important research lines, epidemiology of vascular disease in Lombardy, prevalence of deep venous thrombosis, endothelial damage, and hypercoagulability in acute ischemia. Today in Italy, as the result of last Saturday, 168,000 confirmed for disease. Total death, 22,000. Total recovered, 40,000. Health workers infected, 200,000. And in conclusion, Mr. Greenhalgh, I think that it's very important the role of centralization hubs, not increase prevalence for aortic emergency, but hypercoagulability can lead post-operative complication, high prevalence for peripheral disease, and very important, I would say, improve personal safety in the healthcare environment through appropriate use of PPE. Thank you for your attention.
Thank you very much, Roberto. They are sensational experiences, and the most sick patients a vascular professor can expect to be confronted with, and some of them also with the COVID virus as well. It's quite an extraordinary experience you described. I found that the first one which you showed, the migration type 1 endoleak, very tricky, and that you managed to do an open correction there. Must have been in the background of an extremely high risk of mortality. Would any of your endovascular team have considered the possibility of preventing that further migration by using stent systems, or was that completely impossible?
Really, what's not possible in this situation. Really not possible. Not possible. Right. You try, you think to do, but really not possible.
Exactly. Well, there you go. That was the thing I wanted to bring up for you. Certainly, the circumstances which you showed us, the patients were in extreme difficulty, and I'm left seeing a number of situations where you have provided miraculous results, and patients have come through it. And also we've learned how Milano was at the center of such huge exposure to COVID and how you dealt with it. So many congratulations on your group, you and your group, for that leadership and the information we've learned from you during this time. And thank you very much for presenting this for the Charing Cross session in 2020.